In this video, I will be discussing about acute bacterial meningitis, and abbreviation it is known as ABM. Definition: bacterial meningitis is an acute purulent infection within the subarachnoid space. It is important to understand. It is in the subarachnoid space. It is associated with CNS inflammatory reaction that may result in decreased consciousness, seizures, raised ICP, and stroke. See, meningitis means inflammation of the meninges, not inflammation of the brain. But what happens is, in most of the cases, whenever there is inflammation of the meninges, the inflammation spreads down to the brain parenchyma, or there is at least some inflammatory reaction because of the cytokines, which kind of affect the brain parenchyma, and that causes decreased consciousness, seizures, and raised ICP, and stroke in severe cases. The meninges, subarachnoid space, and parenchyma are all frequently involved in the inflammatory reaction, right? Then it becomes meningoencephalitis and it no longer remains meningitis. So meningoencephalitis, you will find the features of both meningitis, that is neck rigidity and fever and headache, and also the features of encephalitis, that is headache, fever, seizures, loss of consciousness, or decreased consciousness like stupor, coma, etc. So these are the features of encephalitis and meningitis may overlap, and that condition is known as meningoencephalitis. And when bacteria causes it, it is called as acute bacterial meningitis or acute bacterial meningoencephalitis. Etiology: 50% of the cases are caused by Streptococcus pneumoniae. Neisseria meningitis remains the second most common cause. Then group B streptococci, Listeria monocytogenes, and Haemophilus influenzae type B. They are also important. Clinically, acute fulminant illness or sometimes subacute infection that progresses over several days. Classic clinical triad. क्या है triad? Fever, headache, and nuchal rigidity. These are the three findings. They occur either in combination or without combination in more than 80% of patients. Raised feature of ICP include depressed level of consciousness, Cushing reflex, and CSF pressure of opening pressure of more than 180 mm of water. What is Cushing reflex? Bradycardia, hypertension, and irregular breathing. Right. This is the Cushing reflex or Cushing triad. Depressed level of consciousness like stupor or coma may be there. How will you diagnose this patient? First of all, whenever the patient comes to you in the emergency, in a state of altered sensorium, or in a state of fever, headache, nausea, vomiting, projectile vomiting, nuchal rigidity, right? You suspect bacterial meningitis because it is fever, and it is most of the times it is bacterial. And the first thing that you have to do is draw a blood sample for blood culture before initiating the antibiotics. And after taking blood cultures, it is our goal is to administer the antibiotics within first 60 minutes. I mean, as soon as possible. How is that possible? You just withdraw the blood sample for culture, and immediately you give antibacterials antibacterials and adjunctive dexamethasone therapy. It is initiated without delay. Diagnosis of bacterial meningitis is made by the examination of CSF. Here we are concerned with the diagnosis. Why are we emphasizing on blood culture? Because it is a very important step. First step is this: initiate the antibiotics, then draw CSF, because antibiotics will not have any effect on CSF within 4 to 6 hours, right? So you can always withdraw the CSF later on, but blood cultures and antibiotics, these steps must be done prior to them. So what you will see in the CSF. See, it is very important to remember the CSF findings of the acute bacterial meningitis, because it has been asked in the number of entrance examination number of times, and also it is very important on bedside, and it is very important for diagnosing and treating the patients of acute bacterial meningitis. So what is there in the CSF findings of acute bacterial meningitis? It is a table from the Harrison's. See, opening pressure is always more than 180 mm of water. See, up to 180 is normal, and it is always more than 180, and it is seen in 90% of the cases. So it is a very specific finding that opening CSF pressure is high. WBC counts can be up to 10,000 cells, and all of them will be neutrophils. What are neutrophils called? Otherwise, polymorphonuclear lymphocytes, all polymorphs in short form. So WBCs are polymorphs most of the times. PMN, polymorphonuclear leukocytes. RBCs are absent in non-traumatic tap. Glucose is less than 40 milligram per deciliter. Otherwise, it is more than 2/3 of plasma glucose. It is in normal scenario, but if it is less, it is very much suggestive of bacterial meningitis. CSF to serum glucose ratio is less than 0.4. The normal is 0.4 or more. Protein is elevated more than 45. Gram stain is positive in 60%. Culture is positive in 80%. PCR detects bacterial DNA. Right, very important table. Must remember. You cannot afford to forget it. DD. Differential diagnosis, it can be viral meningitis, meningoencephalitis, rickettsial disease, Ehrlichia, also known as ehrlichiosis. It is also bacteria. Subarachnoid hemorrhage can also be there. And uvea meningitis syndromes, Vogt-Koyanagi-Harada syndrome, it is an autoimmune syndrome in which the uvea, that is the iris and the muscles of the iris, they are involved along with meningitis. It is Vogt-Koyanagi-Harada syndrome. Subarachnoid hemorrhage is also a DD of acute bacterial meningitis. How do you treat acute bacterial meningitis? See, what is our goal? First of all, when the patient arrives in the emergency, we do not have blood cultures with us. We do not have CS culture with us. What do we have to do? Because it is an emergency, we have to empirically give the antibiotics to the patient, no matter what. How do we give? How do you how do we come to know that which antibiotic to be given? That is called as empirical antimicrobial therapy. That is why we have to give empirical antimicrobial therapy, because we do not know the organism, but we know the common organisms which cause the meningitis. So in acute bacterial meningitis is a medical emergency, and the goal is to begin antibiotic therapy within 60 minutes of a patient's arrival in the emergency room. Right, understood. Empirical antimicrobial therapy is initiated in patients with suspected bacterial meningitis before the results of CSF gram stain or culture are known. Yeah, I got it. This is the table from the Harrison which tells us which antibiotic to be used. In this video, I will be focusing on the adult medicine only, and so adults, no, not this one. Adults, immunocompetent children more than 3 months, and adults less than 55. These are the commonly uh, seen patients which come in the emergency with acute bacterial meningitis. What do we give? We give cefotaxime, ceftriaxone और cefepime. इन तीनों में से एक, राइट, इन तीनों में से एक हमें देना है. इन तीनों में से एक हमें देना है. ओहो, इन तीनों में से एक हमें देना है. सिफोटैक्सिन, सेफ्ट्रेक्सोन और सिफिपाइन. Plus we have to give vancomycin. Why vancomycin? Because we have to cover MRSA, right? Cefotaxime and ceftriaxone, they cover Neisseria meningitis and they cover Streptococcus pneumoniae also. These are the most common organisms which cover, which cause meningitis. But MRSA can also be there in hospital acquired settings, so we have to add on vancomycin prophylactically. Why do we add, let me clear it. Why do we have to add ampicillin in those who are more than 55? Because in adults with more than 55 age, Listeria monocytogenes is a very common organism. So we have to give uh, ampicillin in these patients. Hospital acquired meningitis, post traumatic, post neurosurgery, neutropenic patients, or patient with impaired cell mediated immunity. What is the problem with these patients? These patients are at increased risk of Pseudomonas aeruginosa. It is a very difficult to treat organism, and we have to add meropenem for it. Meropenem is 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 active against Pseudomonas aeruginosa. Though cefepime is also active, but better than cefepime is meropenem. You can add ceftazidime or ampicillin for Listeria, ceftazidime for uh, either Pseudomonas, meropenem for both Pseudomonas and Neisseria and Streptococcus, vancomycin for MRSA. So we have to cover all the organisms whenever the infection is hospital acquired. So this is the rationale of using uh, empirical antibiotic therapy before the blood culture or CSF culture results are arrived. Now, how do you give specific antimicrobial therapy? You have to remember a few names for that. First is Streptococcus pneumoniae. What is active against Streptococcus pneumoniae? It is ceftriaxone. What is active against Neisseria meningitis? It is ceftriaxone again. Then what is active against Pseudomonas? It is meropenem. What is active against MRSA? It is vancomycin. Right. What is active against Listeria? It is ampicillin. Right. What is active against Haemophilus? Ceftriax again. What is active against Streptococcus agalactiae? It is ampicillin again. When do you have to add metronidazole? Whenever there is otitis, whenever there is mastoiditis, whenever there is sinusitis. We suspect anaerobes in these scenarios, so we have to add metronidazole, right? So this is the specific antimicrobial therapy that you have to give. See, specific antimicrobial therapy will be guided by the culture reports. What is the benefit of reading and specific antimicrobial therapy is we come to understand the empirical therapy. Why are we giving these antibiotics in empirical therapy? The rationale is the particular organisms which are responsible for acute bacterial meningitis. What is the prognosis? See, if treated properly at time, prognosis is good, but still, prognosis includes 3 to 7% mortality in influenza, meningitis, or group B streptococcus. and it is 15% mortality in Listeria monocytogenes. So Listeria is very important. We have understood it is more prevalent in more than 55-year-old, and we have to give ampicillin for Listeria monocytogenes. So that is all about acute bacterial meningitis. I hope you will have read and understood a lot of things about acute bacterial meningitis. Thank you for your patient listening. Thank you so very much.